This conference will now be recorded.
And sharing their experience from dealing with COVID-19 over the course of the last few months. Dr. Henderson is an emergency medicine consultant at St. Thomas's Hospital in London, where she was also clinical lead. She's currently the president of the Royal College of Emergency Medicine. She was previously the CPD director and registrar and holds an MSc in healthcare risk management with special interest in process and quality improvement of patient care. So without further ado, I'll hand over to Katherine.
Thank you very much indeed. I'm just going to share my screen and then hopefully we get going. Can everyone see that as a screen? Fantastic. So thank you very much indeed for this invitation to speak. I'm going to talk about lessons learned, focusing particularly on the lessons learned in the emergency department world. I think everyone will probably be aware that the UK has had quite a torrid time with the COVID pandemic. It's not been easy, and there will be, I'm sure, lots of areas to explore. But if I focus mostly on what's been happening in the emergency department, I think that may be the most useful thing. So what I intend to cover is obviously a bit about the UK timeline, which is obviously a little bit different from where other parts of the world. Some of the main lessons of the surge, key lessons for emergency department, the things that we wish we'd done better or could do better and still could do better if there's a second wave. And also what is happening now that we are officially coming out of our lockdown, and there is a great deal of desire to restart services within the NHS, but what a Royal College or any specialist body can do for its members and fellows to support the specialty along the way. So just a reminder for those of you who are not aware, the United Kingdom is actually made up of 4 nations. And healthcare policy is actually a devolved policy area, which means that there can be slight differences between what is done in each country. A lot of the data I'll show you relates to England and Wales. Scotland has done very well during all of this, and indeed has had several days recently where they've been reporting no deaths. And they have a slightly different lockdown strategy coming in and coming out. We have a population of 66 million. Importantly, and I think this is important for the European question as well, we have an old population, 18% of the population are over 65, and we're also an ethnically diverse population, and sadly that becomes incredibly important as we go through the UK experience of the COVID pandemic. So when we went into the pandemic, we weren't in a great place, it has to be said, in the emergency medicine world. We were a system under immense pressure. We were seeing rising demand. We were seeing long queues. We were seeing crowded departments. And we had this horrible thing that we dubbed corridor care, where patients were in corridors waiting to go up to the ward. And at the start of my presidency, that was the big thing I was working on, was saying we cannot have crowded departments. We have to have more beds. You can see our bed position in the graph on the bottom. And we need more investment in healthcare in general, and you can see the per capita healthcare spend. So things weren't terribly good when we went into this, and it has to be said that crowding is an international emergency medicine problem, and the International Federation of Emergency Medicine this week are launching some guidance and thoughts around crowding because it is such a big issue. Just a reminder of the sort of the UK timeline. You're all aware of the international dates, but from a UK perspective, our first 2 cases were identified in the very end of January. 2 Chinese nationals were identified, and then fairly soon afterwards, a UK national who had been in Singapore and had managed to travel to the UK, out to a ski resort and back again before they presented with symptoms. And those were our first patients. And at this point, what emergency departments were involved with was we were having to test well people, travellers, returners from these areas, and we were dressed in spacesuits, in pods on our ambulance ramps, testing patients then. We'll talk about what happens in February, but the next main date sort of nationally was the 3rd of March, which was our first death. And then by the 6th of March, we as a college had to make a decision about mass gatherings because there wasn't any national guidance about this yet. But we decided that having 380 emergency medicine clinicians holed up in a hotel in a seaside resort was probably not the thing to do, and so cancelled our face-to-face conference at that point. And then as time passed, the international recognition that this was a pandemic, we moved through the phases of attempting to contain, and we hit lockdown on the 23rd of March. So that's when we went into full lockdown with the stay home, protect the NHS and save lives message from the centre. So between the first cases and the first deaths and that full lockdown, what was going on in emergency departments and in hospitals in general across the health service? So the big thing was obviously a lot of redeployment of staff. There was skills assessment done of staff, and people were reallocated from the areas where services were being shut down. An awful lot of elective services just stopped, and people who had skills within ITUs or in emergency medicine were redeployed. So we spent a lot of time doing a lot of induction and training and preparation for people who maybe hadn't recently been working in that environment, or indeed some people ever been working in that environment, so that they were up to speed. And nationally, final year medical students who were nearly qualified were pushed through very, very rapidly so that they had a role, a legitimate legal role within the health service so that they could work. And a load of doctors and nurses who had recently retired were reintegrated into the health service so they could take roles. There was a lot of changes about space, rotas were simplified, a lot of pathways were changed, and it was realised that there was going to be an issue for staff well-being. Although I don't think we realised the amount of space that needed, at least it was identified as an issue, and so plans were put in place for people to be able to debrief. The messiest bit at this point was around personal protection equipment, and I think internationally this has been an issue. People feeling that they didn't have the right kit given the level of risk that they were facing. And it took us a bit of time in emergency medicine to fight our corner for the risk represented by the undifferentiated patient and the risk represented by doing things in a resus room where patients would be being intubated and aerosol generated procedures. We actually had to demand that that was recognised in an area similar to an HDU and an ITU. And the problem with that was it was a waste of energy. It was uncomfortable, it was difficult conversations, and it has rumbled on as an area of debate and concern. In the pre-hospital part of the emergency care pathway, what was going on was staff recruitment to our national call line. It's been very advantageous to have a national call line because that became the place that everybody rang to get advice about what they were going to do, whether that was just to quarantine, whether that was to get a test ultimately, or whether that was to come into hospital. So ambulance conveyance pathways were changed, and our primary care system, so that's a very much a main feature of the NHS, is that primary care doctors are the gatekeepers of the NHS, moved a lot of their services to remote services only, and were able to provide a very, very good service using video and telephone conferencing. But at this point, testing regimes were problematic. We didn't manage to, and the phrase is always, ramp up our testing regime. So back when we were doing testing on pods of pretty well people, we were testing all of those patients, and if they were positive, they were all being admitted. We ran out of capacity to do that and then moved to only being able to test patients who were going to be admitted. So we even weren't testing some patients who were going home. We got a national flow chart of how to manage COVID patients very early on, which was incredibly useful and is the same as nearly all international ones, but it did make it quite straightforward to decide what you were going to do with patients and to risk assess and have consistency about patient experience across the system, moving patients through. And ultimately, for some of the green patients who were going home, we were able to develop follow-up services and also some testing of higher risk patients, so that if they did represent, which obviously a number of them did when they deteriorated, we knew their status as they were coming in back into the system. And there was it was an amazing learning process during the main surge, which we've all shared internationally, I think, the amount of information and the clinical interest that has come about because of this, and I'll just mention some of those ones. But then, as things progressed, we got into some more difficult territory around ethnicity, around age, and around deprivation, and then more recently, nosocomial infections has been a particular area of concern. So the first thing to say was, symptomatology, getting people on the list as to what was the symptoms. That took a bit of time to get, for example, loss of sense of smell on there. But differentiating severe cases and not severe cases was quite hard. But as we all know, breathlessness was by far and away the most worrying sign that people had. And I'm sure everyone's had the same international experience on that. Fluids were an issue. When we first started in the UK, the message was run people dry. This is like ARDS. It became very rapidly clear that that wasn't the right thing to do. And there was a time in the UK when there was more concern about renal replacement therapy, both kit and reagents, than there was about ventilators. So having watched Italy, there was this huge concern about ventilators. We never have had a problem in the end with ventilators. We had more than enough, but renal replacement therapy at a time was very tight, and that became a focus. And so fluid balance became a big focus. The other thing we learned early on was that diabetics are particularly affected. The UK has an obesity problem, metabolic syndrome, type 2 diabetes is rife, and we found that diabetic patients were presenting extremely unwell, and quite dramatically. We even saw patients with hyperglycemia and ketosis as their presentation of COVID. And so we rapidly got guidance out about that and shared that around the country, which was good to do. Proning became a thing. Proning that was the sort of just in ITUs in the past, moved out of ITUs onto wards and then eventually into EDs. And we learned about the benefits of that, and that was also extremely interesting clinically. And then COVID and thrombosis, which was a big area of discussion internationally, was discussed a lot. And it was very interesting to realize that different countries had different thromboprophylactic regimes, so that what for us was standard practice, that a patient on ITU would get thromboprophylaxis, didn't seem to be the case in some other countries, who were then reporting that COVID was giving rise to large numbers of patients with clots. So for us, that's never been as much of a feature as a surprise, because we already gave patients on ITUs anticoagulation. But what was interesting was that D-dimer was so obviously associated, very, very high D-dimers, such as I had never seen, was associated with fairly poor outcomes. So where are we now? We're now very much over our peak, and we hope that our numbers are going to continue to go down. But we've got some local outbreaks. We've had local outbreaks in hospitals, which we'll talk about a bit later, but we've got one city that has been stopped from this weekend. We're due to have quite a reduction in our lockdown measures, and they are being delayed. So we've now, for the first time, got one area of the country that's not going to have the same reduction in lockdown as the rest of the country. So that's a slightly unusual place to be. And as you can see, it's all been about major cities. Our big cities are where most of our cases have been, which you would expect in many ways, but there's other bits of this that have sort of blindsided us. Not so much the age. We knew that this was a disease that was affecting the elderly, and we know that we've got an elderly population, but it has been quite marked how much our deaths have related to the older population. And really, the reality in the UK is that under 44, your chances of dying were minimal. And the people who have died, who are in that age range, have tended to have significant comorbidities. But the older, the more deaths. And there are obvious differences in the nations in the percentage of the population that is elderly. But it's not been, and the Northern Hemisphere has an elderly population, but it's not been a uniform experience, because although Britain has, the UK has an elderly population, the median age is still younger than Germany, and it has to be said Germany has managed its older population better in terms of the number of patients who have died. And this has been one of the hot topics of the UK and one of the difficult conversations in the UK, and has been reproduced in other countries. But it's been the issue of care homes and the number of deaths that have happened in care homes. Now, patients go into care homes for a reason. They usually have comorbidities, they're usually frail, and therefore they are vulnerable intrinsically. But the care home system in the UK is not like the NHS. It's not owned by the NHS. It can be a big company that runs a number of care homes, or it can be, small family-run care homes. So it's much more difficult managing it consistently. And that, I think, is something that we need to learn for the future, that this is a vulnerable group that needs to be protected. We've now got national training programs for infection control for care homes and access to PPE. But at the beginning, all of that was delayed, and testing has been delayed in care homes. And as a result, it's a population that's difficult to keep social distancing going with. And so I think that's one of the sadnesses for the UK, is the number of patients who have died in care homes. Going on along with that has been this issue of missing patients just not turning up to the ED. And I know that that's going to be talked about in the next talk as well. But we've seen that. Some of it you'd expect. People are not crashing cars, they're not falling off building sites, they're not giving themselves food poisoning by eating in dodgy restaurants, they are not hammering nails into themselves in the way that you would expect. And they've not been drinking as much, which for a UK emergency department is a big deal. We've seen a 60% reduction in patients presenting with alcohol-related issues. And they're beginning to come back, but there clearly has been a worry about patients not presenting with stroke and MI, and we're seeing late presentations, so patients with perforations, which we haven't seen, we haven't seen perforations like it for years, and yet we're beginning to see that. And then the other difficult aspect of this pandemic in the UK is how much it has highlighted issues around ethnicity, and that the ethnic population in the UK has been much more vulnerable to not necessarily getting COVID, but having a bad outcome if they have contracted COVID. And that, at the time when Black Lives Matters, the death of George Floyd, has meant that there has been a real questioning about what is going on both within healthcare, within social care, within attitudes, and also deprivation scores. And this has raised a lot of hopefully uncomfortable conversations, which may lead to us actually working through some of these problems and getting some real action as a result. Because the ethnicity issue and healthcare workers has highlighted it, that among healthcare workers, it has been ethnic minorities that have suffered the most. We all know about SARS in Hong Kong and in Toronto, and how healthcare workers are vulnerable in these sorts of pandemics. But in the UK, it has been a particular group of the healthcare workers that have been vulnerable, and ones who have maybe not got so much access to PPE or the ability to get trained. And that's something that we've had to recognise and now do risk assessments in healthcare staff to try and make sure that the most vulnerable are protected and don't have such bad outcomes. And deprivation has been highlighted. We know that there are health inequalities in the UK health system, but COVID has really highlighted them. So the combination of ethnicity and deprivation and age has raised a lot of questions and things that we're going to need to work on in the future. Moving on to what is currently a big worry, which is nosocomial infection. Again, the Toronto experience and Hong Kong experience of SARS. We have already had one hospital that had to close for a fortnight because of a local outbreak. We've had teams that have had to quarantine, and we've had departments that have had to close. And that clearly is something that we want to avoid at all costs. And so now in the UK, we've adopted the sort of Hong Kong, Singapore standards of masks everywhere, visors everywhere, not just in clinical areas. But we all kind of hope that there's going to be a bit of a nosocomial dividend for emergency departments in this. We all have issues with MRSA. All of us will have spent painful afternoons contact tracing when somebody with measles or chickenpox has come in. And we hope that generally a reinvigoration of infection control measures will be useful, and that we'll also benefit from a commitment to improve the estate of an emergency department such that they are fit for purpose, plus the issues around crowding. We produced our own IPC documentation as a college to try and help people do that. But what else has been the effect in the UK is training. There's no question, a college is responsible for training, and so that's been one of our core functions that we've had to worry about. We've had to cancel exams. We're now doing exams online, which has had to be sorted out. There have been lots of training opportunities missed, specific skills because of the change of case mix. I mean, dramatic change in pediatric attendances. But people who were in anaesthetics, there's been no routine anaesthetic lists. And so they all got redeployed to intensive care units where they're not getting the same skill set that they're going to need for their EM training. We've done virtual interviews, and all the kind of annual appraisals that a trainee would expect have all had to become online, and we have had to note where they have training gaps. And that's going to take, a year to sort that out for those people to get the training that they need. What else have we been doing? We've been doing a lot of sharing of experience. We've been trying to make sure that we make sure that no one makes the same mistakes as other units, that we make sure that international information is shared as quickly as possible, and that we have pragmatic solutions to problems. The college itself has been closed, like I'm sure lots of places, and everyone's been working from home. And the other big activity of a specialist body like ours is advocacy. And that's particularly valuable when it comes to this restarting, coming out of the pandemic. There's been masses of joint working. One of the most wonderful things that has come out of this is the amount of joint working that's going on. So the major positive is now that it is absolutely accepted that crowding in emergency departments is dangerous and unacceptable. And there are lots of schemes being worked on to make sure that we have models of care that don't let that happen. Everybody gets that this would be a bad thing to do. Emergency departments will still remain being the safety net for patients, but in recent years, we had become the safety net of the system, and that is no longer possible. We have to have a better system than that. The pandemic has highlighted health inequalities in a very uncomfortable way, but I think it's made it essential that we address that. And it has also been clear that with joint working, we can make sure that we are better prepared for a second, third, fourth wave, or whatever the new pandemic is in years to come. So thank you very much.
Thank you, Catherine, for that wonderful talk. I'm just waiting for a couple of questions. I have a question myself, and this is regards to training, which is what we sort of, in terms of our own residents. So obviously, all exams have been postponed. So what we do regionally is we do something called the Arab board exam, so which has been postponed. So our final year residents are no longer able to sort of do their exit exam. How do you manage that? And I'm sure I have lots of friends in the UK who were close to CCT and haven't been able to give their exit exam. So how do you manage that transition? Do you extend training? How does that work? I don't know, it's quite, or do you give them step-up roles, as an, acting consultant or something? How does that work, and how does that figure into the college statements?
So we have to maintain the same standard according to the General Medical Council. That's core to this. We're not allowed to make a different standard. But what we can do is we're working incredibly hard to get any pinch points, like people who would have a next step of their progression. So we've been able to progress some trainees who haven't got some competencies by giving them a specific COVID-related outcome from their appraisal. So it would have been called an outcome 1 in the past. It's now called a 10.1, which is a COVID outcome that recognizes that they're allowed to progress to their next bit of training, but that they've got competencies that will need to be completed. In terms of exams, we are going to have to extend some people, but we are rapidly getting them online. And so we've got our first in July. We are sitting our SAQ exam online, and we will be doing an OSCE exam online very shortly as well. So we've worked incredibly hard. You have to get permission from the GMC to accept how those exams are done. But as long as we cover the same competencies as we would have done in the exam. If we do it by a different methodology, then it becomes acceptable. But it takes planning and it takes buy-in from trainees. So talking to trainees, explaining to them, making sure that they understand what's going on is very, very important for all of this.
Brilliant. I mean, I'm assuming it would take a big effort in terms of doing exams like OSCEs virtually. So it's going to be quite challenging to do it when you're not seeing
I'm signing up to be an examiner in all of them so that I can see how it works in practice. I will be marking SAQs in a few weeks' time.
Brilliant. Brilliant. Thanks for your excellent talk. We'll wait for the questions, and if there are any questions, we'll have them at the end, if that's okay. And thank you for sharing your experience. So I'd like to introduce our speaker from Belgium. He's a very good friend of mine, Professor Ives Hubloue. He's trained extensively in internal emergency medicine, intensive care, and disaster medicine. He's got a PhD in medical sciences. He serves as the Emergency Medicine Residency Program Director, and he's also the chairman of the Strategic Management Board of the European Master in Disaster Medicine. So I'll leave the floor to Ives now.
Thank you, Omar. Thank you for having me invited for this webinar. I feel very honored from my part to share our experience from the past weeks, and thank you to ESEM for thinking about me and having me in this webinar. Our talks coincidentally will be complementary to each other. I would like also to thank Katherine for her nice overview from a macro level, and I will just abort the problem of COVID-19 from more a micro level. But honestly saying, Katherine, all what you were sharing with us, we can just replace the word UK by Belgium or even by Europe, because we went to similar issues. So what I would like to do in the next couple of minutes is giving my experience from 2 points, from the EMS point of view and then also from the emergency department, how we ran through the past 15 to 16 weeks. I shared also these data with other European countries in a research project and a common project we have. So things that I'm telling about Belgium can be also easily said about other countries. So let's start. So with some general features, the data until June 26, we had about 61,000 patients with proven COVID in Belgium. And Katherine was talking about the nursing facilities, and about 9,600 were of those patients were tested in nursing facilities. And I'm coming back on that later, because this was also a major issue in Belgium and the rest of Europe. Just some details to explain you why Belgium at a certain moment was on the top 1 level in number of deaths per 100,000 inhabitants. As you see on the slide, we didn't report only the positive proven cases who passed away in the hospitals, but we also reported on possible cases. So this gives us a lot of higher numbers, and which put us at a certain time in the top 1 position of the dead people. So about 17,000 until June 26 were hospitalized in Belgium hospitals, and these are data coming from an official government organization. So let me talk about first EMS organization, why I'm doing this, because maybe it's interesting to other people to know a bit the EMS organization in Belgium, a bit similar to France and to Germany, is that we have a call center, the 112, which is integrated with police and fire brigade, and with a medical backup where there are doctors and nurses sitting behind the telephones and responding to calls and regulating the means that are sent to the patients. Our system on responders is three-tiered, as we call it. We have ambulances with EMTs, mainly based in fire brigades and staffed by firefighters. They have a basic training in first response, and they are not paramedics. And then we have an intermediate system, which is a hospital-based ambulance. And on the bottom right, you see the picture of the ambulance from my hospital, where an emergency care nurse, together with two EMTs, is going out on the scene, dependent on the type of call and the alert level of the call. And then the third is the mobile intensive care units, or in France they call it a SAMU, where a rapid response car with an emergency care nurse and emergency physician is going out on the scene. So this system was also a bit under pressure, and a bit rather under pressure during that COVID first peak from the past weeks. And I'm just sharing our experience because we are actually having a paramedic intervention team in our hospital, and we have that mobile intensive care units also. So these, at a certain moment, also our government decided in the ambulances, the basic ambulance, to make like COVID special dedicated ambulances. If there is a call that came to the 112 dispatch center and it was highly suspected for COVID, this type of ambulances were sent out on the scene. And then these are pictures from also my hospital, where you see the emergency doctor and the nurse with personal protective equipment going out in the rapid response cars. And so this was also an issue besides the organization of the ED, where we had to work on in the past weeks, and probably also when a possible second peak would arrive. This is just to show you the map of Belgium on the left, and you see the red dot in the middle, Brussels capital, and actually the red dot is exactly on the spot where my hospital is. And on the right bottom, you see the catch area in dark green and whiter green. So we're going the dark green inside the capital of Brussels, but then also you see in the suburbs outside of Brussels, where it's less dark green, where our ambulances and our rapid response cars are actually interfering. As I said, the fast car team is an emergency doctor and an emergency department nurse. The paramedical intervention team, it's called paramedical, but it's not the same as the paramedics which you have in several countries. So it's two firemen and an ED nurse that are staffing the ambulance. Between March and June, beginning of March and June 23, we had about 1,000 fast car calls, and for the ambulance, just half of them. And the specific calls for COVID, when it was highly suspected, are reported there. Probably there are more, because there, you know, it's very difficult, and this was something the dispatchers were reporting, and still today, just based on the phone call, to decide whether you should send the COVID ambulance or whether it should be a COVID call for the rapid response team. We were very strict on that and said, if there is a doubt, and I showed you on the pictures on the slide before, when you had a doubt, you just put the personal protective equipment before going on the scene. Just here, a very busy slide, just to show you that our fast car interventions, they were not so high during that period of the past weeks. So around 10 to 12 interventions a day. One day, 27th of March, when we had the peak in Belgium, and I show you later, then we went up to 16 interventions a day. And in the orange bars, you see the ambulance interventions with the nurse. So it's a rather steady graph. And why is this? Because Brussels, the capital of Brussels, is rather well staffed by other hospitals that also provide these kinds of vectors in the EMS system. So we were never overcrowded or overworked or overdone in that particular way. So indeed, what I would like to share with you, and then I will end the EMS and go to the ED, is what did we learn, positive lessons, then what could be improved, and what are future challenges. And I will do that the same when I'm talking about the ED. The positive lessons learned from the past week, that I noticed a flexibility of all personnel in general. We prepared beginning of March until mid of March when the activity started to raise, and we had time to train, we had time to organize, etc. And what I was amazed by was the willingness and the flexibility of all the personnel involved in the EMS of our hospital to work, and even outside. What we did also in that short period of time, we developed new COVID approach protocols for the basic ambulances. We developed new COVID approach protocols for the paramedic teams and for the rapid response car. And then what was an interesting thing was that the government decided to get a central regulation by the 112 dispatch center about where the patient should be transferred to. So there was an overview of the available beds in Brussels hospitals where patients could be transferred to, and this made our work much more easier, because you didn't have to call by yourself to the hospital and discuss and explain the case. No, it was done by the dispatch center itself. And then the fire brigade, you know, when going with PPE, you have to decontaminate your ambulance if you had a transport of a suspected or a proven case. So the fire brigade of Brussels took on their shoulder the central decontaminations of all the ambulances, and this was also taken off of our shoulders. And the inter-hospital transfers were done also by three people, by three organizations: the Belgian Red Cross, and you see an ambulance from the Belgian Red Cross on the right bottom. And then an important effort was done by the medical component from the Belgian Army. The military hospital in Brussels is very nearby to my hospital, and they actually provided in the whole country, in each province, 1 to 2 ambulances staffed by paramedics from the medical component, just to do those inter-hospital transport. And then some private ambulance companies also participated in that. This was also regulated by the 112 dispatch center, which in normal situation we don't have, but now during this crisis, this was done centrally. What could be improved? What my experience is, and this is like in each crisis, I missed at certain moments the command, control, and coordination should be done like what I called a gold command. So some dispatch centers were working in different regions, etc. And this was made sometimes a bit difficult. Belgium is a very small country, but even then, if you have to report to 2 to 3 dispatch centers for the 112, this is difficult to work. So I would expect in the next months or next years that there, in situation of a crisis, we come to what we call a gold command. And of course, you have always individuals who don't stick to protocols or to regulations, and sometimes hospitals, they did not report their exact data on available beds, and so then the central regulation was difficult. Logistics, Katherine already said or tackled the PPE. This was a major, one of my nightmares, is the availability of PPE for the pre-hospital, and you will see the same for the ED in a few minutes. And actually hospitals had to manage by themselves, although all those EMS vectors like the ambulance and the rapid response cars are public services, and I expect then that the government or the authority should provide us with the adequate logistics. The management of the waste was also an issue. A lot of ambulances, they just dropped their garbage or waste in the ambulance bay of each hospital, so we had to take care about that. And this is also something we should learn or change in the future. And then what we should improve also is training of personnel. I'm coming back on that later on. We had some time when we saw all the pictures and the reports from Italy and Spain in the early weeks of March that we said, okay, we have now time to train, but training of personnel and just-in-time training or hands-on training or other kinds of training are things that needs to be improved. Future challenges: adapt the current protocols for the EMS operations outside the COVID peak. We are now a bit outside of the peak, but okay, we should be careful because there are, as also Katherine said, local outbreaks that are popping up, and this will happen in Belgium too, and we will not escape to that. So we should have a flexibility in our EMS operation. I would very like to have that central regulation of destination of ambulances towards hospitals at any time now. It's like in France they have it, and this works very well. And so together and in parallel with that, a federal driven command, control and coordination in periods of pandemic or peaks or other crises and scare better resources will help us a lot. Provide also a central program for decontaminations of vehicles or other stuff and waste management. And then finally, I'm very active in training of residents, but also of other students in emergency medicine and in disaster medicine. So this is one of my passions. And so again, training programs for all personnel on everything should be tackled anyway. This was my first part, which was on the EMS. Now, just again, also from the micro level, how did we tackle it in the ED itself? This is an overview of the hospital where I work in the north west of Brussels. In the center, you have the hospital. In the back, you have the medical school. You have the brown building is the children's hospital, and at the right side you have the outpatient clinic. So it's a campus where you have a hospital, a medical school, and a nursing school. So we are basically a university teaching hospital with about in the ED 80,000 visits a year, level 1 trauma center, and where 1/4 of the patients are children. And as I said, we were part of the Brussels EMS system, and with an ICU department with 30 beds, including pediatrics, an OR with 20 rooms, and a post-anesthesia care unit for 20 positions. And our hospital is actually a reference center for diabetes, oncology, fertility, and cardiology. So what happened about the hospitals in brief and on a micro level? In March 12, we had a national hospital disaster plan activation done by the Ministry of Health. And in the hospital, we installed the Crisis Command Center on March 13, and we stopped all non-urgent activities in OR and OPD on March 14. And then in the next weeks, we based actually our activity on two parts. We increased the search for intensive care and infectiology wards. And so these are the three words I will come back later, and which are for people trained in the disaster medicine. They are very familiar with that: structure, staff, and stuff. So new ICU wards were created, medium care units were created, and a COVID wing in the hospital was created also on the 4th floor of our main building. Staff, as all the activities of non-urgent in OR and OPD stopped, we reallocated doctors, nurses toward what we call the COVID departments, which is the ED, the ICU, and then the COVID wing from internal medicine. And then, of course, we focused on stuff. We focused on PPE, ventilators, and lab testing. And also, again, as Katherine said, fortunately, we didn't have a lack in ventilators. We had ventilators enough, and you will see that in the data I will show you. From my department point of view, the organization of the ED, we organized it in a COVID and a non-COVID area. We made new protocols, and I showed it already, pre-hospital, but also in hospital. And we trained our people, especially on the PPE use, and I will show you some pictures how we did that. The crisis cell in the hospital was established, and the chair of the emergency department, what I am, is part of that, and it's led by the chief medical officer of the hospital. And then I also established a mini crisis cell within the ED, where there is a mix of doctors, nurses, and administrative personnel. And our main task was looking at that staff and structure on the ED level. And I had a core theme, which you see a picture on the left side, and on the right side you see our daily meetings. And fortunately, this is a good picture where we are not wearing masks. Some of them are wearing masks, but we are already taking care about the distance when we are doing the meetings. So what we did on the staff, we created new shifts for doctors. I will not go into detail. And then you can also read what's on the bottom of the slide. We were reinforced by other departments, from doctors, but also cleaning personnel. From nurses, we got other nurses from other departments, mainly from the fertility department, and they were actually our backup in what we call the buddy system. We also had a lot of help from our medical student, because also medical schools stopped working, and our medical students were reoriented in their clinical rotations towards the ED of our hospital. So I'm very happy that we had a very tough time to work with all those personal protective equipment. But here you see the total sick days of the ED personnel from March to May. And I just want to show you, we had only 5 proven cases of COVID during that time. So I'm very, very, very proud on all the staff, doctors, nurses, and administrative personnel, because they did a very good job on wearing their PPE. So there were other figures in other hospitals in Belgium, but I show only these of my hospital. So this is a very positive message. So in the structure, we transformed the ED, and so we separated in a COVID and non-COVID area with new walls built, patient flow that changed, and some areas that had to be redesigned and re-equipped with materials. We also changed flow in the ambulance bay, and the meeting rooms. We had some meeting rooms. We need to take care about social distancing, but also the meeting rooms became the place for catering of our personnel, because the central kitchen and the central restaurant of the hospital was locked down, and so there was a real reorganization within all the hospital. And then, as I said, PPE was my major concern. Also, the storage was a bit done everywhere, and I will show you also some pictures of that. Then also we needed to provide dressing rooms for putting on the PPE, and this is not always easy to find, because it should be done in very proper and safe way. And so, but we found a solution on that. Some pictures to give you an impression how in a quick time some temporary walls were constructed just to close and to make the difference between COVID and non-COVID. And on the bottom, you see that the dialysis unit of our hospital was made into an intensive care department within 2 working days. So to talk about stuff, I'm just coming on logistical problems, and PPE was really a nightmare. It was a shortage. There was a shortage from the beginning, and it was hard to find. Everybody was struggling nationally, but also internationally. And also the stockpiling was a problem in the hospital once we got the PPEs. So I transformed a part of the ambulance bay into a stockpiling for PPE. So a major issue was also the control of PPE. We got a lot of, I'm sorry for the word, crap that was not, if you buy an N95 or a FFP2, it was not FFP2 when you open the box. And so it was tested locally, and this was also a major issue. We should be aware when we have the second peak that we have the adequate and the right PPE to work. Pharmacy, I'm lucky to have a clinical pharmacist in the ED, and she was very active in creating new medication cards, and she actually coordinated all the stock on the PPE, the masks, but also the aprons and the gloves. Here are some pictures of the staff working within the ED, the COVID area. On the right side, you see a senior resident who's doing the triage, fully equipped in her personal protective equipment, ready to receiving COVID positive or COVID suspected cases. This is the ambulance bay, turned out into a stockpiling of all our personal protective equipment. And also on the left bottom, you see also oxygen supply for our rapid response cars if necessary. Gives you an overview about some figures about pieces and numbers on PPE. We will not go into detail, but just for the moment, I have about 222,000 of aprons that are piled up in the ambulance bay, just to be ready for a second wave if necessary. So logistics was a very big issue during the past weeks. Just to give you some data, and then I finalize with the lessons learned and where to go. We were not overwhelmed like in Italy and in Spain. So there are a lot of hospitals in Belgium on the whole country. We were also lucky to have, in normal circumstances, about 2,000 ICU beds in pre-COVID situations. And the government asked us to double up that capacity, and we did that. Each hospital did that. And so we had a rather big capacity for hospitalizations and even ICU, so that the dramas and the disasters that were seen from television from certain countries in Europe, fortunately, we did not have. And so in our hospital, until today, 465 confirmed COVID cases were hospitalized, 144 on ICU, and about 81 passed away. This is a bit a difficult graph to see. I would like to show the next one, where you see actually the total numbers of the ED patients, and this is the beginning of March at the left, the blue bars, and you see that we are mainly between 200 and 300 patients a day, and at a certain moment there is a lockdown, and Katherine also mentioned it. The lockdown was mid of March, and then the blue bars, they dropped, and then in the orange bars you see the number of COVID patients coming to the ED, and then you see our peak at the end of March, early April, about 124 to 128 patients a day, COVID patients, and then we went over to the peak, and now we are at the right side of the graph, where normal activity represented in the blue bars is getting up again. So we are not again at the 200 or 250 numbers of patients a day, but we are between 150 and 200 patients a day. So we had that drop in normal patients with AMI, with stroke, etc., and we have a dramatic drop in pediatric patients again. So here also I just pointed out, you see the peak in the beginning of March, at the beginning of April, end of March, and then at the right side you see two small peaks. This is exactly 2 weeks when there were measurements of the lockdown that were diminished by the local government. So like shopping that was allowed again, or family visits were allowed again, etc. And then fortunately you see then that there are again some peaks, and now it's staying very low, and the last days we have only 1 or 2 patients that are COVID suspected entering the ED. That's a graph. I will skip it. The hospitalization of people on the wards. This is maybe not interesting to go into details. Just here, an overview of our critical care, and you see that in the ICU, March, which is in blue, April is in orange, that we saw that in the ICU, most of the people were hospitalized in March. Mid-care units that were created to increase our search capacity, they did not accept a lot of patients. And then you see here our normal ICU capacity on the right side were 30 beds adult, 6 beds of pediatric. We had no mid-care. And so we went up in our COVID crisis up to 30 beds adult, 6 beds pediatrics, 10 beds coronary care, 10 beds of mid-care. We transferred 10 beds of post-anesthesia care unit into intensive care, and also 10 OR rooms were turned into an intensive care unit. But you see that we were never overwhelmed by patients. In total, we had 121 patients who were on the intensive care. And there, Katherine, I have to say our mean age was not so old. We had our mean age of patients were 57 to 58, which is rather young. But we also saw the elderly patients. But our mean age was about 55 to 60. So to summarize, positive lessons learned, again here, a flexibility of all personnel in general. We had a very quick response by our technical department in rebuilding. Actually asking to put a wall was 2 seconds later execution. We had a large support by our facility management, by cleaning, by food. The biomedical engineering department, they did a marvelous job because we tripled our ventilators. Old ventilators were reset and rebuilt, etc. And then what was very interesting was the multidisciplinary meetings regarding medical treatment. People find each other without any command. People from the ED, infectiology, pneumology, ICU, microbiology. So the working together was very good. And in the ED, I was amazed by my staff, the flexibility, how they did it. They came up, the residents came up with new shifts, the nurses came up with new shifts. There was an enormous solidarity, and I was very proud about their professionalism. And I showed you the graph of the personnel infected in the past weeks was only 5. So I'm very proud on that. To be improved, again, the command, control, and coordination. I think we should learn from the military. In disaster medicine, they learned us a lot, and a unified command in a crisis is a standard. And I think this is one of the feedbacks I will give to the board of the hospital, that we need to stress on that unified command in the future. Also compose the crisis cell to a smaller group because it's regulated actually by law in Belgium, and because this will give you a better control of individuals who will not follow the rules. Logistics, lack of medical experts in the committee that were responsible for that. At the end, yes, but from the beginning, logistics is an issue. And so we need to assign tasks to people who is responsible for what, who will be taking care about the medication, who will be taking care about also the PPE, and who is doing other things. So we need to give a good task assignment. And then finally, the mitigation, going back to normal. We are, since 2-3 weeks, we are going back to normal, back to business. That needs to be considered from the beginning of the crisis, because upscaling a hospital is a rather easy thing to do. This can be done in 24 hours, but downscaling a hospital is a very complicated task, because you still are there with a mix of the risk patients and the non-risk patients. And my personal view on this was a bit initiated too late in our hospital. And then finally, training of personnel. Future challenges, very briefly, adapt our current hospital disaster plan towards flexible tools. The structure of the EDs, also keep them flexible, because we will have the second wave. So we don't need more days or to change it again. So we should make a flexible structure, and that's also adapting the flows outside of COVID peaks. And then keep a reasonable stock of validated PPE. We should know that our PPE is safe for our personnel. This is a major issue. And then meanwhile, now we are also catching up, like Katherine said, with the learning process of our students, our residents, etc. But we should be repeating some of our standardized protocols in the upcoming weeks to be prepared for a second and hopefully not a third wave. So training is for me an important thing. You could do this by pre-event, by organizing drills and just-in-time training. Our main focus was the correct use of the PPE. You can do that in with PowerPoint presentation, with movies, but I noticed that real life training by putting on and taking off the PPE is still the most important thing to train. And so fortunately, this shows some pictures from a drill we had in February, 2-3 weeks before it happened, on the CBRNE, and you see the ambulance bay on the left bottom on the CBRNE protocol, and it was done with students and residents. And luckily, when I said, okay, we have to work with the PPE, our personnel said, okay, like in the drill we had some weeks ago, and this helped. So in calm periods, we should try to mobilize our people and train. Another challenge for me is we were overwhelmed by Belgian chocolates. Here you see a picture of the chocolates I received from an organization, and so this led to a rather important increase in body mass index of our personnel, getting them to the risk group. So managing the chocolates is an issue for the future. And finally, this is my last slide. We were very honored that our hospital received the first visit. It came out the first time of the Royal Palais. Our king visited our hospital when it was a bit outside of the peak, and so we were very honored to have him and giving us support for all the work we did. So thank you so much, and this was my sharing of experience from Brussels.
Thank you, Ives. We've got a question for you from the audience. So the question is, did you have to recruit non-emergency department staff or non-emergency department specialists to operate the COVID or non-COVID emergency department?
Yes, we did. Actually, they volunteered by themselves. So I showed the slide, but I went rather quickly, not to stick too long. We got residents from internal medicine, we got residents from surgery, and residents from pediatrics and especially the surgeons, they were not operating anymore the planned operations, and they came just to say, okay, just tell us and teach us what we should do. And that's okay, we will put you in the non-COVID area. No, we would like to see those patients, etc. So we gave a basic training during shift handovers, etc., about how to put on the PPE, how to watch, etc. So they were never alone in the area, and they were always backed up by emergency physicians, etc. But yes, we had, that was for the doctors, and the same, Omar, happened for the nurses. Our nurses went into the patient's area and went into the rooms where the patients were, but as we worked with the PPE, we had to give like the blood sampling or the lab testings, etc. Before they went into the central system. We had to hand it over to a non-infected person, and so all those other people that came to help us, they functioned like, we called it a buddy. And so all the fertility department, our hospital is very well known for fertility, and so all those people, the fertility department and hospital and inpatient clinic was completely closed down for many weeks, and they came to help us as a buddy system. So yes, we had a lot of other, that's what I called with the solidarity of personnel. And still today, okay, they left, okay, because normal activity came back, but they still are there, and they said, once you need us, call us and we will come back.
Sorry, the next question is for Katherine, and then I think Ives can talk about that as well. So Katherine, the question is that now that we are slowly coming back to normal business in the emergency department, most of us have sort of restructured the department to have sort of clean and non-clean areas, which is obviously a little bit arbitrary anyway. But now that you're going to see more patients coming in with usual stuff, you know, your MIs, your strokes, do you still maintain this demarcation between sort of COVID and non-COVID, considering that you might have a second peak at some point in the next few months? How does that sort of relate to, or would you continue on doing the same in terms of department structure and sort of patient stream flow?
Yes, I think hospitals are at slightly different stages. Those who have still got quite a lot of patients coming in are maintaining those two completely separate flows. And it also slightly depends on your facilities as to whether you've got side rooms or not, or developed side rooms. So we're doing a risk assessment at the beginning of the patient journey, and we're trying to persuade people that actually that should be part of your basic streaming activity. We're interested in making sure that shielded patients, so the patients who were kept safe because of comorbidities for weeks at home, who might now need us, we need to make them reassured that they can come to the emergency department. So we want them to be identified early via our national 111 system, so that we know they're coming, and then we can get them into a safe side room so that they're not exposed to anybody else. We're also, anybody who we risk assessed as possible COVID will go into a side room, but we've now got a sort of ambulatory majors area and our other majors area rather than a COVID, non-COVID. And within that, that means that we're wearing a lot of PPE all the time. Now that's tiring, it's dehydrating, your skin starts falling apart, but we've got to make the workplace safe for everybody. So we've got to make it safe for staff, and we've got to make it work for all patients. And that's why we're working very, very hard to try and have, very unusually for particularly UK emergency departments, some sort of control on who's coming in, trying to make it not just the default option for particularly very, very vulnerable patients. So they've got somewhere else that they could be accessing the care that they need. It's complicated, but yeah, we can't just have a duplicate emergency department and carry on.
Can I add something to that, Omar?
Absolutely.
Yeah, Katherine, I fully agree. It's only a few weeks ago that we stopped having the COVID, non-COVID, because you cannot continue to work with you had to double your staff anyway for that. And so that's already an issue. The only thing we should be, and we also wearing PPE all the time, and this is stressing the personnel. But anyway, this gives the message towards the population that it is safe to come to a hospital when you have a major problem, because this was what we saw during the COVID peak, that all those people with AMIs and strokes, they were not coming to the hospital. We saw in the past weeks a lot of perforated appendicitis, etc., and because people were afraid to come to the ED. So the message that Katherine also said is that we should keep working safe for our personnel, but also give the message to our population that you can still come to the ED when you have a major issue, and you will not have a higher risk to be infected there. Are you agree, Katherine, on that?
Yeah, no, absolutely. We've got to get the right people back, though. So we're trying to make it possible for someone who's well known to the oncology service to not have to access their care that relates to an oncology problem through the emergency department. Too much in the past, our specialty teams have always had as a sort of default option on discharge, if you've got a problem, go to A&E. And I saw somebody yesterday who'd been, popped in a car by their son-in-law and driven from Brighton to London, which is a 50, 60 mile journey, because they're used to coming to this hospital. And we just can't do that in the future. That's not a sensible move. No one was expecting that patient to turn up. It makes no sense at all. So we've got to try and ask for a very big change in the way the population has managed emergency care and it's going to be a journey, I think would be the kind thing to say.
Yeah.
Great. Ives, I've got a couple of more questions, one for you, and I think one for you, and then one for both of you, and then we can close the session. So this question is, as the preparedness lessons from this cycle, is there any take-home message from you for possible the next biological incidents or similar peaks of COVID, as healthcare systems have been de-escalating their systems?
Yeah, I saw the question from Shazak. Thank you, Shazak, for asking me that question. Thank you. It's a challenging one to respond. So people now think, I'm not saying I do and Katherine do or all the participants do, that it's over. And so my first message is that just be prepared and be alert that this thing can restart again. So the lessons learned and what we do now, we revised our protocols, we revised our organization within the hospital, and we made of that a more flexible way in upgrading, downscaling, etc., so that this can be done in a few hours, etc. So this is my main message. So make protocols, make checklists that you can go up or go down again, and be vigilant. Be vigilant. Follow all the local data on outbreaks, what's happening in the center of UK now, but what happened also in Germany locally, what happened a few weeks ago in Italy in a certain region where they had to close down a hospital or they had to close down an apartment block. It can happen. There are local outbreaks, and this can affect your hospital. So you need to have a flexible response system to go to upscale again. This is my major answer on that, Shasa.
Yeah. So we've got one last question, which is addressed to both speakers. This is from Manny. Was there any increase in your isolation negative pressure capacities in the emergency department? At my current hospital, we managed to split our recess into 50% negative pressure rooms, and also converted our short stay CDU area into 8 isolation rooms. Will there be changes in the emergency department design in preparation for the next pandemic?
Can I ask already? Can I answer, Katherine, or would you like to go first?
No, you go first. Fine.
Okay. To answer that, we constructed, and the images you saw on the screens is a brand new emergency department that was built in the past years. So we already have negative pressure rooms in our ED, in the adult section and in the pediatric section. The only thing, they are not enough in numbers to cope with a pandemic from this side. So putting everything in negative pressure is a major action logistically and technically to be done. We thought about it, but it's a very high cost, and I discussed this also with the microbiologist and the people, the infectiology specialist, and they came up with always the same advice, that the personal protective equipment by the personnel individual is the best thing to do. If you're constructing a new department in the future and money is not an issue, you can take care about that. I will not rebuild my ED now, making half negative pressure and half non-negative pressure. So that's my personal view.
So from the UK's point of view, it was clear that we surveyed, and it was clear that we didn't have enough isolation facilities. I would agree. You need to have some negative pressure, but you can't just put in a negative pressure room. It's a massive undertaking putting in negative pressure rooms. And what we needed was single rooms. We needed things that we could close off and separate. So there's been a lot of redesign of departments to achieve that, and that actually can be done quite well. The issue is you've got to be careful that you have got enough ventilation. If you don't have enough ventilation, you just open the door and just everything comes out. So what you've got to be working on is how many air changes does your area have? Otherwise, you can just get yourself into somewhat more difficulties. But the key thing is, in that case, PPE. So I think if I had the possibility of completely rebuilding, that would be a very different situation. I think we would all be wanting more side rooms. Now, I'm quite lucky. We're a fairly new build, and we have got quite a lot of side rooms. But there are some very, very old departments in the UK that are desperately needing a rebuild. And so as part of our kind of advocacy of what's going on nationally, we need to make sure that we've got emergency departments fit for purpose. But frankly, we needed that before COVID. Just in as much as we need it now. It's just that we've now got the ear of everybody in a way that we didn't have before because the stakes are so high. And as everyone says, never underestimate the possibilities of a good crisis. Make what you can of the crisis that you're in, and make sure that we've got departments that can serve our populations as well as possible.
Brilliant. I mean, we, from my own personal experience, our own resource area wasn't negative pressure. So we had to redesign the whole department as to where we would take our resource patients. And we were, as you said, more focused on isolation rooms rather than negative pressure rooms, because we obviously didn't have capacity to build a negative pressure rooms within a very short period of time with the obvious expense of it and so on. So it's not something which is practical unless you're designing a whole new department with unlimited money, which is not obviously quite the case in general.
No.
Brilliant. So it was really great. Again, I want to thank you on behalf of the Emirates Society of Emergency Medicine for giving us this really productive lecture. I will send you a link with the YouTube to all the people who attended, who would like to show it to colleagues who couldn't attend it. I'll send it to Ives and Katherine as well. Again, thank you once again on behalf of the Emirates Society of Emergency Medicine for coming on at relatively short notice and giving us a comprehensive view of what's been going on in Europe and what to expect in the next few months.
You're welcome.
Brilliant.
Thank you. Thank you so much. Thank you.
Good to see you
Take
all.
care. Have a good day. Bye-bye.
Bye. Bye. Bye, Mani.